Okay, good afternoon. My name is Amit. I'm a first-year radiology resident in Shiva Tel HaShomer. I'm going to do a case that's a little bit of an elaboration on something that Dr. Morag touched upon at the beginning of the day, if anybody remembers. So here we go. This is a 68-year-old female, generally healthy. She's had long-term pain in her left hip. And after seeing an orthopedist in the community, she has a suspected labral tear or a femoroacetabular impingement, and she was sent to our institution to perform an MR arthrography. So this woman had many pathologies in her hips. As you can see in this axial T2 images with and without fat suppression, she has a bursal formation, a peritrochanteric bursal formation. She had an impingement cyst. She had conjugal defects with conscious material entering where the schos, cartilage should be. So here we have a full scan of the actual T2 with fat suppression, and as you can see here, there's a pathology that exists on both sides, and this will be the topic of what I'm going to discuss. So what is the pathology? It's not 6. This is an MSK convention. 5, that's right. Ischiofemoral space narrowing with quadratus femoris muscle edema. Let's see it again. As you can see, bilateral edema of the quadratus femoris muscle. So let's talk a little bit of the anatomy. The quadratus femoris muscle goes between the ischial tuberosity and the femur. It's bordered by superiorly by the gemellus muscle and inferiorly by the subgluteus fat pad, along with all the neurovascular bundle that goes there. In addition, we have the hamstring tendons and the iliopsoas tendons medially. So we have a case of ischiofemoral impingement. This was first reported in '77 by Johnson, mostly as a sequela of hip surgery. And what it is basically a narrowing of the space between the ischial tuberosity and the lesser trochanter of the femur, which we call the IFS, the ischiofemoral space. The quadratus femoris muscles, which passes through the space, is impinged during repetitive hip movement, which gives rise to pain and due to the narrowing of the space through which the muscle passes. This is another view of the anatomy where we can see in a more 3D sense where the quadratus femoris muscle passes through as it passes between the two bones. So how do we get to this diagnosis? MRI is the gold standard because it gives us a good picture of what we're looking for, and it has good inter and intra-observer reliability, so it doesn't change between one radiologist and the other. The hallmark of the imaging is the narrowing of the ischiofemoral space and the quadratus femoris space, with the normal size is 23 millimeters for the first and 12 millimeters for the second. But you have to remember that this is a very active joint. And usually MRI is not we don't usually perform a dynamic MRI. We certainly didn't at our institution. And so the measurement depends on hip rotation, the adduction and extension during MRI. So if we said 23 millimeters and 12 millimeters, for this woman, the right side had 16 millimeters and 25 millimeters respectively for the ischiofemoral space. But the quadratus femoris space was 13 and 11 millimeters, which explains why she had pain. There was a narrowing of the space. So what do we see when we perform an MRI? As far as the quadratus femoris goes, we see fiber crowding, we see myofascial disruption up to a tear. We see edema around the hamstring tendon attachment, and we see edema around the iliopsoas insertion. We see bursa-like fluid surrounding the lesser trochanter, which we saw before, and we can see perisciatic fat stranding, especially if we have back pain, if it comes along with sciatica. So we're back to our patient, and you can see we have several of these pathologies. We have the muscle edema, we have the iliopsoas tendon enhancement, hyperintensity, and we have the bursa-like fluid collection around the femur. There's a very, very wide clinical differential diagnosis, which was already discussed today, so I won't go over it again. And as far as treatment goes, there's no definitive treatment. The treatment begins with conservatively with physical therapy. Nowadays, we move on after that to arthroscopic decompression with resection of a section of bone to relieve pressure, and up to including muscle resection in very advanced cases. And last resort is lesser trochanter resection, which is a much more major surgery with more sequelae after it, but it's still something that can be done to relieve the pain. So, as far as some questions, which of the following is not a possible etiology for ischiofemoral impingement? It's not the long answer. Male 6. Women get it more. And the why? Because of the greater angle between the two parts of the pelvis, there's a shorter space between the ischial tuberosity and the femur, leading to a narrower space and a higher likelihood of impingement. Here you have many reasons for impingement, including congenital or primary reasons, or secondary reasons, either how we're built or how we perform. And okay. And what is not a common MRI finding in ischiofemoral impingement? Okay. Bone marrow edema. We said while bone marrow edema can happen, it is not a common finding, and while the others are very much common findings, we see the edema in the muscle, we can see partial or full tears, and edema in the surrounding fat and bursa formation. Thanks.